Hello, doctors. Is that hearable?
Yes, ma'am.
Yes,
Hello.
ma'am.
Yes, ma'am.
Okay. Sudden, there's a call down and it's dropped down. So sorry. And actually, sometime emergency schedule, there's some breakdown. Sorry for that. So remember very carefully, my dear candidates. Already from the initially, I already discussed regarding the shock. What I'm review few points. Some points. Just mute the mic. Actually, I strongly said mute the mic. Okay. I'm reviewing few points because some points maybe we didn't record it, so it's also initial part. So I want to be till those points regarding the shock I discussed regarding the distribution cardiogenic shock, hypovolemic shock, and I already discussed the spinal shock, why neurogenic shock, and the presentation and the discussion of this question done, why it is this hypovolemic shock, and there is a description nicely written. Already I discussed just shortly. I'm review those points because sometimes the recording was broken. Hypovolemic shock always important. Blood loss volume 10 to 15% for the stage 1, stage 2 for the 15 to 30%. Stage 3 very important. And the management stage 1 is the IV fluid and stage 3 4 is the blood transfusion. So hypovolemic shock and cardiogenic shock, we have to remember the elevated pulmonary capillary waist pressure. Elevated pulmonary capillary waist pressure we have to remember strongly because it goes towards the value either it's a hypovolemic and cardiogenic. My dear, can you strongly remember another point that pulmonary capillary waist pressure. Pulmonary capillary waist pressure is goes towards that it is this only point goes towards the cross sectional pressure is this what cardiogenic shock can be differentiated by elevated pulmonary capillary waist pressure. Okay, it's more than 18. Pulmonary capillary waist pressure or cross-sectional pressure is a pressure measured by pulmonary catheter. So what does it mean? It also goes towards this cardiogenic shock. In hypovolemic shock, pulmonary capillary waist pressure is not important. Second question will be discussed with me, Dr. Sajma. Yeah.
Yes, ma'am. A 35-year-old patient presented to the emergency department stating that this is the worst headache of my life. Physical examination reveals neck rigidity. The neurological examination is negative. Lumbar puncture reveals blood in the CSF. Which of the following is the most likely diagnosis? It is C. Ruptured berry aneurysm.
It's a it's a rupture berryism. So, Dr. Sashma, I am asking that what are the points towards the rupture berryism?
The worst headache he is having, plus there is blood on the lumbar puncture picture, and there is neck rigidity. So they all suggestive of subarachnoid hemorrhage, which is due to ruptured berry.
Okay, excellent, excellent. Ma'am. Thank you, Dr. Sashma. Thank you. I'll discuss later. Okay, thank you, Doctor. Dr. Reza Oruzi is here.
Yes, ma'am.
Yeah, third question.
An adult patient present to the emergency room with his friend. The patient demonstrates pinpoint pupils and is lethargic. Pinpoint pupils means three things: one opioid, one I think infarct, in 1.1 section in brain. And a physical exam reveals decreased respiratory rate, decreased breath sound, and red track marks on the skin. Oxygen saturation rate is 88%. A friend of the patient confesses that they had been getting high on heroin. What is the best initial step management for the opioid? The best first management is before intubation is intravenous naloxone, and after that it needs intubation. The option will be C.
So, Dr. Reza, my question. First of all, you have to tell me what actually happened here. First of all, tell me what actually your information.
The point is they were using heroin, opioid, and pinpoint pupil means they use opioid. The antidote for opioid is naloxone, intravenous naloxone. Option C.
Yeah. This question, okay, Reza, just mute yourself. I'll discuss this question with Dr. Dr. Nipuni able to talk? If no, this question will be discussed with me, Priscilla.
Yes, ma'am. So my point is, I'm thinking because there's decreased respiratory rate, decreased breath sound, and the oxygen is 88%. My initial step is intubation first. B.
Excellent, excellent, excellent done. Dr. Reza, you already diagnosed its opioid toxicity, but strong point, Dr. Priscilla, extremely done that this value, oxygen saturation. You are the emergency doctor, Dr. Reza. You are
Yes.
the emergency doctor. You can't wait. You can't wait for deterioration of patient. It's not important for my naloxone. It's not. It's not. Why important is the respiratory security. I have to secure the respirator. I have to give the respiratory support. Clear?
Yes. ABC.
Okay. Thank you. Thank you.
Thank you.
So just Dr. nicely explained Dr. Salzman's question regarding the rupture aneurysm, cerebral hemal. Nicely said it's a rigidity, ma'am. It's a rupture aneurysm. Regarding the intubation, Dr. Priscilla, excellent done that, ma'am, there is a saturation drop in, respiratory drop in, so we have to do first intubation. Later, whatever the first step management and it's ABCD support, airway, breathing, circulation. So actually, I believe everyone excellent, but what happened when we see opioid toxicity, we do naloxone, but no. I have to read surrounding information for secure my question. There is a dropping oxygen saturation. There's an in decreased respiratory. So I have to secure you, and they said you are the emergency doctor. Even after passing exam, you can be, and there will be the viva, and there will be some hospital setup. So every question they'll ask, okay, and there you have to take the LSBL certificate, everything. So we have to be very careful this question. Sepsis question, my dear candidates, very important that remember. Life-threatening organ dysfunction caused by hot respiratory infection. I want to tell you again one word, few part from first. The recording was breaking, but I just ensured this question what I discussed regarding the blood loss. So I always ensure that keep trying to be active in the Zoom. So life-threatening is an organ dysfunction which goes towards a sepsis. So question to be asked dealing sepsis. So what question we have to ask, is the patient acutely unwell or not? Because is that patient needed ICU support or not? Does total is the score, whatever the GC score, is that below 5 or not? Is there any single new score added or not? Okay, so is GCS dropping, septicemia ongoing? We have to monitor all things, and there's a red flag. If the answer to any of the question, my dear guys, look the red flag for the septicemia sepsis patient. We have to remember systolic blood pressure, heart rate 130, saturation below 91, respiratory rate more than 25, response only to voice or pain on response, lactate more than 2, urine output below 5, below 1.5. So all are the red flag sign we have to strongly remember. So why? Because these are the red flag sign which goes toward the septicemia. So if one or more, there is the red flag sign, what the number here? The red flag sign number here is 7. So if one or more red flag sign, complete sepsis 6 without 6 minutes. So means what? That first of all, take 3 means what? First of all, initially we have to see follow take 3. Take 3 means blood culture, clotting, lactate to see the DIC, and we have to check the urine output to see the renal function. Give 3. So we have to give IV fluid, IV antibiotic, and oxygen. So take 3, give 3. Septic shock, my dear candidates, low blood pressure, we have to ensure IV fluid and vasopressor. Exam question. Septic shock, what inotropic support we have to give this vasopressor as agent, and we have to ensure means what? We have to ensure mean arterial pressure more than 65, serum lactate more than 2. My dear candidates, this red flag is very important along with septic shock. How we manage along with IV fluid, still patient is not maintaining the blood pressure value, we have to ensure vasopressor. Severe sepsis means sepsis with organ dysfunction, so oliguria, lactic acidosis, cerebral dysfunction on dysfunction ongoing sepsis, severe sepsis. So remember that how organ dysfunction identified. You have to identify this altered mental retardation means what? Either hepatic encephalopathy or LTST impairs hepatic function, impair respiratory rate more than 22, systolic blood pressure below 100, septicemia ongoing. So my dear candidates, so see shaking, anxiety, shivering. Okay, shaking it can be caused by any kind of pyelonephritis, biliary sepsis, or it could be any kind of malaria. My dear kind of septicemia picture. What we'll take blood culture to see the septicemia. We have to analyze the urine output. We have to analyze the platelet level, and we have to ensure the antibiotic. Though we have to maintain the shock mean arterial pressure more than 65 by vasopressor or IV fluid support. Okay, and identification of the organ dysfunction by altered mental stage that or respiratory rate or systolic blood pressure by below 100. This question will be discussed with me, Dr. Nipuni. Okay, Nipuni said she is on duty. Dr. Nandini Sharma.
Yes, ma'am.
Yeah.
Yeah, a child presents to emergency department with a blunt abdominal trauma. An upper gastrointestinal series revealed a coil spring appearance in the retroperitoneal duodenum. Amylase levels are high. Which of the following is the best next step in the management? Bowel rest, gastroenterostomy, CT guided needle for hematoma extraction, laparotomy and hematoma evacuation. I guess, ma'am, it's laparotomy and hematoma evacuation.
If the Dr. Nandini is talking with me, Dr. Nandini, for yourself, I am discussing like you say, I come to the hospital in emergency. What you are doctor, and you see that my child having blunt abdominal trauma. Okay, and you are emergency doctor, and you are checking and the gastrointestinal series. I mean, you are doing X-ray or ultrasound, whatever. The gastrointestinal series reveal there is a coiled spring appearance in retroperitoneal duodenum. So coiled spring appearance means what? Coiled spring appearance means it's not any foreign particle. It means our abdominal intestinal gut are congested. That's why it is spring down. Retroperitoneal duodenum means there is shadow and the obstructive or retroperitoneal fluid involved here. So which of the following next step? Next. So first of all, Dr. Nandini, gastrointestinal cross. CT guided needle hematoma extraction. Needle hematoma CT guided already I done, and there is spring appearance. It's a not major complication. So CT guided needle hematoma extraction is not mandatory right now cause blunt trauma only called is appearance means my abdomen congested appearance.
Yes.
Laparotomy and hematoma is not now my patient is not emergency situation, not unstable that I have to do a laparotomy or obstruction or there's tearing or there's a perforation. There's nothing.
Okay, ma'am.
In gastrointestinal series, there is nothing for doing any laparotomy and there is nothing to doing CT guided extraction for hematoma. There's nothing. There's just congestion and it appears. There's a coiled spring appearance. Clear, Dr. Nandini?
Yes, ma'am. Yes,
So
ma'am.
what
Yes.
is the answer? Next is bowel rest. Dr.
Yes, ma'am.
Nandini. Okay,
Yes, ma'am.
clear. You clear. I said what? So see, Bowel rest involve liquid. I mean what? You will give what? Only liquid diet. Duodenal injury manifest. I said that injury only isolated hematoma, isolated or congested hematoma. GI series indicate intramural hematoma. So intramural means what, my dear? Like I just hurt by my hand by a furniture or any I hurt by my hand, and it's a interma just slight bluish. My hand injured and the sluggish hematoma. It's the intramural. Just mute the mic, doctors. Mute the mic. So this is the intramural hematoma, Dr. Nandini. Clear? So
Yes, ma'am.
there's no so high. So you intramural hematoma indicates and high bowel obstruction. So initially, so there's no perforation. There is a spring appearance. So having hematoma, there's a congested in nature. There's a possibility of having obstruction. So we have to initially what we have to do, Dr. Nandini, we have to do bowel
Bowel.
or parental nutrition.
Okay, ma'am.
Okay,
Ma'am.
clear?
Yes, ma'am.
The question that Nandini marked that a hematoma extraction, no, because the obstructed the needle, preventing the percutaneous drainage, no, it's interrupted. If you insert the needle, it interrupt and it causes major blind injury, and there's no indication for the laparotomy. This chart I given initially when my course started regarding the sepsis search. Even I faced two questions. Sepsis search, this question must, my dear, whose exam very near, strongly remember sepsis search, septicemia. These red flags, they give either respiratory rate or heart rate more than 30 or urine output. So if you find one or more is sepsis. With organ dysfunction is septic shock. If SARS means what? SARS means there is only temperature, heart rate more than 90 along with blood glucose. These are the SARS presentation. Just strongly remember this, take 3, give 3 criteria already discussed. Okay, just remember very strongly. Acute GI bleeding, actually I'll discuss in gastroenterology just for shortly, as they are commonly Blatchford score. Blatchford score, my dear candidates. So what does it mean? Acute upper GI bleeding, Rockkill score, Blatchford score, Nelson criteria already discussed in pancreatitis. Initially, to determine low risk or high risk, you are a doctor of OPD patient. Just you are sitting a clinic. Patient complaining of, sir, I have bleeding per rectally every day. But you have to assess, is it major or minor? And you have to take the blood pressure, pulse. Okay. So for the Blatchford criteria to determine low risk, to determine low risk, though they ask indirectly, how they ask you, they give a long scenario, my DHA hard candidates, MOH candidates, they give urea only 5 or urea 4 or hemoglobin only 110. This way, hemoglobin 110 means it's dropping, but urea 5 means it's okay, it's normal level. Pulse 110 means it's acceptable. So all are the low risk criteria. So this low risk criteria, I can discharge the patient by giving C2 to decrease the blood, to improve the blood constriction, to improve the, to prevent the blood bleeding through the GI tract. If it is varices, if it is melena, what is the cause? We have to take more information. But this Blatchford criteria for determine the low risk assess the OPD basis. Okay. Recall school or Rockhill school assessment admission. You have to do admission. You are a doctor OPD basis, but you need the admission, need the patient. How? Age, hematemesis, hematochezia, ongoing, continue, hemodynamically not stable. You are doing, you are measuring the blood pressure, but it's 90/60 or 80/60. Liver disease, okay. So all goes the cardiac and malignancy, the comorbidity. So you have to do admit the patient. My dear candidates, this Blatchford criteria initially, if it is low risk, we can give terlipressin IV fluid. But if it is high risk, admission need, we have to resuscitate the patient and definitive management exam question to rule out or to see the source. We have to do endoscopy and band ligation. Okay, if INR, if INR prolong, we have to give vitamin K. If platelet count below 50, we have to give FFP. If tips should be considered if bleeding from esophageal varices. So post GIT bleeding due to malariasis. Post GIT bleeding due to malariasis I discussed in my surgery session. Discharge, and we have to see the FBC, and we have to observe the vitals. Indication of FFP very high exam question. When we will give FFP? If platelet count below 50, if replacement of isolated factor deficiency, if prolonged INR, and is a TTP treatment. So we have to remember the criteria or indication of FFP exam. They ask by platelet or they ask by prolonged INR or treatment of TTP in acute setting or patient is not a stable, patient ongoing bleeding. This question from another chapter, but very important exam question, very important. This question will be discussed with me, Dr. Sneha Raj. If Dr. Sneha Raj not here, Dr. Somia.
Yes, ma'am.
Mhm.
A
Easy question. Yeah, very easy
young
question.
female patient presents to the emergency department with abdominal pain, vomiting, and fever. Physical examination reveals splenomegaly and mild jaundice. Ultrasound reveals pigmented gallstones. Which one of the following is the most likely diagnosis? A. Sickle cell anemia, B. thalassemia, C. Hereditary spherocytosis, and D. paroxysmal nocturnal hemoglobinuria. As young female and abdominal pain plus pigmented gallstone, this is sickle cell anemia.
Okay. So, first of all, my dear, here what are the points? Actually, you have to remember that ultrasound reveal this question was also discussed in my session. Okay, and I feel it's very easy. My dear candidates, doctor, remember pigmented gallstone. It's not crisis like sickle cell crisis. No, Dr. Somia, it's not sickle cell crisis. That's I can't determine it's a sickle cell anemia. No, there's nothing. There's just abdominal pain. Like if I say patient respiratory distress, ongoing drop in hemoglobin, I can think regarding the sickle cell anemia. But here they said abdominal pain, splenomegaly, jaundice, and you found pigmented. This only word pigmented, my dear. Only word pigmented goes towards what? Goes towards which diagnosis?
Sickle cell?
I said there is no sickle cell crisis. So
Hereditary spherocytosis.
hereditary parasitis. Only one word pigmented. Only one word. If
Okay.
severe abdominal pain, there is abdominal obstruction, the crisis is another format, but only one word pigmentation. It goes towards hereditary.
Spherocytosis.
Yeah, clear?
Yes, ma'am. Thank you.
So hereditary parasitis question actually common exam question, sickle cell crisis question. Another way they ask regarding the respiratory compromise, there is regarding the dysfunction of the abdomen, GIT complications. So remember this mutation, this already they discuss everything regarding the sickle cell anemia. Why not? Sickle cell anemia always present the mutation of the hemoglobin, which is called extravascular intravascular hemolysis in sickle cell. The hemolysis means dropping hemoglobin. So either patient come to with an sequestration crisis. So sequestration crisis means the tachycardia, tachypnea, respiratory compromise, but no. Hereditary spherocytosis is goes towards extravascular, only extravascular hemolysis, splenomegaly, increase pigmentation of the gallstone. Anaphylaxis question, commonly exam question, they ask two way. Just shortly, I'll discuss this anaphylaxis question. The speed of onset and severity vary with nature. Amount of stimulus means what? Sudden swelling of lips, tongue, pharynx, angioedema may lead to complete upper airway occlusion. Upper airway occlusion. Okay. So lower airway involvement means when there is dyspnea, wheeze, chest tightness, hypercapnia. So the respiratory complication or respiratory suppression due to what they say, due to the natural way or any stimulus, either allergen sensitivity, skin pruritus, erythema, urticaria, angioedema. My dear DHA has every kind of angioedema. They like very much this question, either hereditary angioedema or C1 stress inhibitor, like that with the ask question. Cardiovascular peripheral vasodilation and increased vascular permeability, plasma leakage from the circulation which cause hypertension and shock. We have to manage this patient by ABC, like high flow oxygen, lay patient flat, so below 6. Adrenaline question very important. Just strongly memorize in your head. If below 6 year, it's a 1.5 ml, 1 in 1000. Question asked from the more than 12 years. It's a 0.5 ml in 1 in 1000. This is the dose of adrenal or epinephrine intramuscular injection. Hydrocortisone and chloramphenicol. We have to give. My dear candidates, what are the presentation? If respiratory decompression, first I have to give ABC management. Then I am. Read question very carefully. Don't do mismatch. Every candidate, mashallah, every candidate is excellent. Just we have to read question excellent. If respiratory decompression, initially ABC, definitely adrenaline epinephrine. And the age, if baby 4 to 5, it's a 0.15. Is this to 12, it's a 0.3 ml. So 0.15, 0.3, 0.5. That's it. 1 in 1000 we know very well. So hydrocortisone, chloramphenicol as well we have to give. Sign and symptoms of smoke inhalation injury like stridor, wheezing. Stridor, wheezing, black sputum, use accessory muscles. So what does it mean? The inhalation injury. Inhalation injury goes towards, initially we have to do intubation. If airway obstruction, we have to do tricothyroidectomy. Choking and foreign body airway obstruction. Choking and foreign body airway obstruction. Exam question, infant. They ask shocking question from the pediatric part. How they ask? If conscious, in a seated position, support the infant in head downward, prone position. Exam question. Choking or foreign body obstruction, head downward and prone position to let gravity aid removal of the foreign body. Perform 5 sharp blow, heel of the hand, middle of the back. Okay. So below 1 ear, back blow, the chest thrust, and more than warrior, if it is called Heimlich maneuver. So Heimlich maneuver is another way they give. So remember choking and foreign obstruction, this Heimlich maneuver, back blow and maneuver, just remember by name. If it is conscious, patient stable, that we can perform this maneuver. But if it's respiratory distress, unconscious, anesthetic, if patient if need to removal of the foreign body, we have to do anesthetic support by Major's forces under direct laryngoscopy. Just remember the name. If conscious, if below 1 ear, back blow support in chest and thrust, black bow, or if it is more than 1 ear, Heimlich maneuver, or if it is patient unconscious, respiratory distress, we have to do Major's forceps under direct laryngoscopy. Just remember the name. Just I will ask this question regarding the option. This question already discussed. That's the answer given. So this question will be discussed with me. Dr. Monia Jaman is here to talk with me.
Yes, yes, I can. I can.
I will tell the option. You read the question. I'll
Okay.
tell the option.
Patient presents to the emergency department with paralysis of all four extremities after being involved in an automobile accident. Patient extremities are warm
Mhm.
and pink. Which of the following is the most likely diagnosis? So, what are the options,
Option
Dr. Friday?
Option A is hemorrhagic. Option A hemorrhagic.
Okay.
Option B irreversible. Option C neurogenic. Option D cardiogenic.
Okay. It cannot be cardiogenic. Number one, it should be cold for cardiogenic, warm and pink. So just now you have discussed warm, it should be neurogenic or septic. So septic not possible because just now accident. So and
Yeah.
also there is another thing, extremities are paralyzed. So it should be
Ex-
neurogenic.
Excellent done. Excellent. Thank you, my dear. Excellent done. This is the way
Thank you.
exam question. Thank you. This is the way we have to interpret. Excellent done, Dr. Muniajan. That means very concentrated, listen and listen in the session. This is the feedback that yes, I understand this the topic. This way, even strongly nicely catches the paralysis. Even if
Yeah,
they didn't give the warm and pink, that means even it's the neurogenic. Okay. Thank you, doctor.
most
So
welcome. And it's you, Dr. Irene, it's you who make me concentrate. Usually actually now also I'm in the duty, but whenever I'm getting time, I'm entering. You excellent way you are explaining. It's really helpful. Really helpful. I
really,
pray for you. Pray for you.
yeah,
Thank you.
yeah,
Thank you
thank
very
you,
much.
thank you, dear Apu, thank you. This is the feedback.
Most welcome.
Really, I feel feel very pleased when my candidates give nice feedback. I really am feel very pleased. Thank you. So, carbon monoxide poisoning question that we have to remember that tasteless exam question. Carbon monoxide poisoning question. Tasteless, odorless gas may occur from car exhaust. How they give, I will tell. Tasteless, odorless gas. You are a doctor. Patient come to you, madam, I have severe headache, and you are doing the temperature mapping. And this temperature measurement showing hyperparesia. Patient complain, ma'am, I have severe headache, and there is a nausea, vomiting, and my wife also, my children also, all are sufferer. This is the background information. So car exhaust, car exhaust, there is a heaters, painters product. Okay, so these are the clue they give. This car exhaust, heaters, painters they give, and patient presentation, investigation, exam question they give, carboxy hemoglobin level we have to do. Clinical scenario, they give either what is the diagnosis. So if they say me, I have headache, my wife have headache, my children, so all, so means they are on the house in which there were fire breeze, or they were in a place in which like garage, car garage, or there's a heater, gas heater, or there's a painter products, all were there. Or they given only one clue, patient businessman, but the business only paint related or painter only. So these are the clue I have to identify for the carbon monoxide poisoning. Investigation, what we will do, carboxyhemoglobin level. Management, clear the airway. We have to maintain ventilation with high concentration oxygen. Okay. Just give me 1 minute, my dear candidates. So, sorry, just there's a load shedding. So remember, carboxyhemoglobin level we have to do, and we have to secure the airway by ventilation with high concentration of oxygen. Okay, that conscious patient, tight fitting mask with oxygen reservoir. If unconscious, intubate the patient. That's it. If conscious, just oxygen, or neither, intubate if unconscious. Indication of hyperbaric oxygen, just remember only one point, because hyperbaric oxygen we give only if any neurological sign of the headache, like patient come, ma'am, I have severe headache, and you are getting the history which goes towards the carbon monoxide poisoning, we have to give the hyperbaric oxygen. If patient loss of consciousness, if patient develop, and you done ECG and there is arrhythmia due to carbon monoxide poisoning. Carbon monoxide poisoning question, very important question. Either they ask by the diagnosis, neither they what you will do or investigation or management. My dear, every candidate is strongly remember carbon monoxide poisoning. Tricyclic antidepressant is also very important topics for the exam. Just remember that tricyclic antidepressant question they ask by 3C: convulsion, coma, or cardiotoxicity. Dilated people, dry mouth, dry flushes, skin, dry urethra, urinary retention, every point they give. Decreased blood pressure, drowsiness, every point you'll get. So dry mouth, dry skin, dilated people, all D are here, so it goes towards the tricyclic antidepressant or amitriptyline poisoning. They ask directly. If sinus tachycardia on ECG or hyperkalemia presentation, it goes towards the, it's a metabolic acidosis. They give pH value will be the low and bicarbonate value will be the low. So all goes towards the metabolic acidosis. Okay. So management, that within 1 hour of ingestion, we have to do activated charcoal. My dear candidate, this note will be provided every step as management. Just remember, within 1 hour, we have to activate the charcoal, IV fluid, and sodium bicarbonate. If so, the prolonged QRS to decrease this QRS complex cause patient, this QRS itself cause arrhythmia. So tricyclic antidepressant complication we have to remember strongly. Okay, very important for the exam. Tricyclic antidepressant, every management and the presentation. So paracetamol overdose, very high topics for the exam, very important question for this. Many candidates ask the management, even exam they ask. What they ask? Shortly, I will tell 1, 2, 3. First of all, initially the presentation they ask stage 1, stage 2, stage 3, stage 4. Remember, initially nausea, vomiting, pallor. I'll give the chart later. After 24-hour hepatic enzyme rise. After 48-hour jaundice, enlarged tender liver, hypoglycemia, hypertension, encephalopathy, coagulopathy. This is the stage 5. So management, if below 24 tablet or below 12 gram, serum paracetamol level is within normal but no hepatic risk factor, with prior discharge, we have to refer psychiatry evaluation. If more than 24 tablet, if more than 24 every 4-hour injection regarding the tricyclic and anacetyl we have to manage that. If see this chart, if below 1 hour, charcoal. If 1 to 4 hour, delay blood sample until 4 hours, because patient come to your hospital within 30 minutes. You will do charcoal activation, but patient come to your hospital within 3 hours. Means if you take the blood sample, it will not detect actual value. We have to wait. Kindly mute the mic. We have to wait. Kindly mute the mic till 4 hours to detect the paracetamol level. If more than 4 hours, paracetamol level along with N-acetylcysteine. If more than 8 hours, N-acetylcysteine immediately. every point in exam they will give either within 3 hour or 4 hour. Just remember, exam till now recall is more than 4 hour. So paracetamol level and N-acetylcysteine we have to start. This management strongly remember, my dear candidates. Okay. Aspirin overdose. Okay, pH value, another point shortly I want to tell. We have to, they give ABG. Commonly many questions they give ABG. Just remember, if pH below 7.3, so when we'll do liver transplantation, King's criteria, pH below 7.3 and prothrombin time more than 100, creatine more than 3, so it's 100, 300, 7.3. Just this way you have to remember, 100, 300, 7.3 or 3 to 4. So all goes 3. It's a King's criteria for doing liver transplantation. So this way, these are the higher topics we have to remember. Aspirin overdose, remember only 1 point, tinnitus and deafness. So tinnitus and deafness, my dear candidates, just remember this ABG interpretation. This ABG interpretation, mixed metabolic acidosis, respiratory alkalosis, you have to understand. Even if you don't know the ABG, no issue. Just remember, aspirin overdose, they'll give tinnitus, deafness, and hyperventilation syndrome, hypokalemia presentation. We have to remember this metabolic acidosis with respiratory alkalosis. That's it. Respiratory alkalosis, two common cause: one, pulmonary embolism; second, aspirin overdose. Just for exam, just remember, or you can note down. Benzodiazepine overdose, cognitive problem, respiratory depression, and interrogate amnesia. So benzodiazepine overdose, we have to remember crash, cognitive problem, respiratory depression, interrogate amnesia, sedation, and hypertension. So metabolic acidosis, which are the drug can cause? First of all, what I have to know for my exam, this is my point. Metabolic acidosis for my exam, I have to remember aspirin. No need to remember metformin, digoxin, alcohol, no. But there is a manual I2A and MD, but for my exam, I only want to remember this aspirin is for respiratory alkalosis, is for metabolic acidosis. Another question I discussed in endocrinology, vomiting, very important exam question. Vomiting, only metabolic alkalosis. I am telling this is the exam question. That's it. Okay. This way we have to remember. This question will be discussed with me, Dr. Fatima. Your Maha Umar.
Yes, ma'am. An 82-year-old man present to the emergency department with a 24-hour history of progressive headache, vomiting, and dizziness. The patient is accompanied by his wife, who is experiencing similar symptoms. The wife was asymptomatic prior to the finding the patient confused and disoriented. On physical examination, both the man and his wife are awake and confused. The patient attempts to get up but is overwhelmed with generalized weakness and difficulty waking to the bathroom. Which of the following is the most likely diagnosis? A. Migraine headache. B. Acute chronic syndrome. C. Carbon monoxide poisoning. D. Depression. Ma'am, is C. Carbon monoxide poisoning. Because patient has progressive headache, vomiting, and dizziness. Um, uh, and
It's a
it's
tough one. And also
yes,
wife also presenting same presentation, right? But
yes, ma'am. Yes,
symptomatic,
ma'am.
but all same. As I said, nicely catch those points. Thank you, doctor. Nicely presentation done. Let's say carbon monoxide present. That's just this is exam question. Just I describe this way they ask. So this is the carbon monoxide poisoning. Thank you, my dear. So CT scan after a head injury. Exam question, my DHA candidates. Just remember, CT scan, they ask two way, either from the pediatric question nor adult question. What we have to remember. For adult, we have to remember who have sustained a head injury and have any of the following, like perform CT head with 1 hour of his wife. If this is below 13, initial assessment in the emergency department, like you are doing GCS scoring, it's a below 13, we have to do the CT scan to evaluation the cause. If it is below 15, At 2 hours after injury, assessment for the emergency department. So below 13, initially, patient come to your hospital within 1 hour. But below 15 means 14, but deteriorating. We have to initially do the CT scan. This is the adult medicine. Respiratory part is another way. Suspected open depressed skull fracture. Okay. Any sign of basal skull fracture. Any sign of basal skull fracture. Hemotymnum or panda eye. Remember this panda eye CSF leakage to the battle sign can severe this to appear. We have to do CT scan. Anyone panda eye or CSF leakage, we have to do the CT scan. Post-traumatic seizure mandatory. Focal neurological defect or more than one episode of vomiting. My dear friends, for the baby or children, it's not more than one episode of vomiting. It's a till 3 vomiting. Till 3 episodes of vomiting, we can wait or observe. So for adult medicine, we have to do CT scan one if more than one vomiting. Basal skull fracture, the temporal bone, external auditory canal, there will be the perforation or rupture. So for adult with any of the following, so remember CT head within 8 hours when? Just only one, like a patient taking warfarin due to the atrial fibrillation, or patient has history of any bleeding, age more than 65, and there is a more than 30 minutes retrograde amnesia. So all goes towards we have to do CT scan within 8 hours. Patient come to me in hospital within 6 hours, and there's any of the criteria. Just remember only one word, any bleeding tendency. We have to do CT scan, that's it. Shortly, I have to do short more. Management. Shortly is I have to stabilize the patient by IV fluid. I have to do CT scan according to the presentation, or CT abdomen or laparotomy according to the presentation. My dear candidates, very carefully listen. If perforation, we can do laparotomy. If patient severe bleeding, we have to rule out the where the rupture it is. It's no role of the ultrasound. We have to do the CT abdomen, but initially it's called first. I will discuss on the surgery later. First means first. First means initially we will do ultrasound, but if it is severe, right upper quadrant stab injury. Stab injury means we have to, and there's liver injury suspected, we have to do CT abdomen initially. So see, indication of first. First already I discussed. Focus assessment with sonography in trauma. Exam question. When we do first, if is blunt abdominal trauma. So first of all, when we do stab injury, we done CT scan to show for thinking of the liver. Very carefully listen. Everything exam question. If it's stable but penetrating, but there's a penetrating injury, we have to do the first. So assessment we have to do the by interperitoneal peritoneal fluid leakage. So renal trauma. Renal trauma, my dear candidate, listen very carefully. We have remembered the patient presented with me with macroscopic hematuria. If macroscopic hematuria, we have to do urgent abdominal CT scan. If CT not available, exam DHA question, recent recall, we have to do intravenous urography. If patient come to my hospital after any kind of trauma, patient ongoing hypertension, there's a macroscopic hepaturia, there's no CT scan if option, or there's no CT scan available, exam question recent, intravenous urography we have to do. Just they are checking what and how you are managing the case. So blunt question or burn question, just remember shortly. There is a thermal injury, electricity injury, and there is a partial thickness, superficial thickness. Though I will highlight 2 to 3 points, it's not so important for the exam. Just for remember, superficial burn, there's no blister. Okay, the superficial burn. Management is own dressing or discharge or bandage. Partial thickness burns, you see, blistering, deep dermal, and there will be the shiny or sensation will be the intake capillary refill bulges. Full thickness, see, there is a loss of sensation, no blister. So why I am telling? I am telling because they ask how they ask in the exam. For the burn, they ask the management. Parkland formula, I will discuss and I'll give those PDF how we have to assess. So first of all, smoke inhalation. So circumference. So remember immediately, smoke inhalation cause burn, cause death. So we have to do intubation initially. Hyperkalemia management, acute renal failure management. Because why hyper is burn cause hypovolemia, septicemia cause acute renal failure. So these are the immediate, early, late complication. But the management we have to remember. Management generally we have to do resuscitation by IV fluid, but adequate analgesic along with the size of the burn. So minor burn debridement on topical antimicrobial as in early debridement, but exam question which one? Major one. Monitor pulse BP, adequate analgesic, IV fluid will give, and we have to ensure urinary catheter. Okay. And for the referee and specialist burn unit, I will refer the patient in burn unit if it is more than 3% of the total body surface area burn and all deep dermal full thickness burn. So crystalloid IV fluid if it is the major burn, or if it is more than 3%, just they give directly. If it is more than 3%, we have to manage by referring the patient in burn unit. This question will be discussed with me, Dr. Hira. If Hira available to talk.
Yes, ma'am.
Yeah.
A 49-year-old farmer presents to the emergency department with respiratory depression, pinpoint pupils, and hyperhidrosis. Vital signs reveal tachycardia, hypotension, and 70% oxygen saturation. Physical exam reveals fine fasciculations in periorbital chest and leg regions. Auscultation of chest reveals widespread crackles and rhocae. The patient further confesses that he has history of alcoholism and depression and has deliberately ingested pesticide. Which of the following is most likely diagnosis? Atropine poisoning, food poisoning, organophosphate poisoning, or shock? Now, I think so it's C, organophosphate poisoning.
Okay. What are the clues, Dr. Hira?
Ma'am, respiratory depression, pinpoint pupils, hyperhidrosis, and he is tachycardic, hypotensive, oxygen saturation is low, and their fasciculations.
Yeah. So all are the point towards the organophosphate poison exam question. So we have to remember these were presentation. I discussed the tricyclic antidepressant, amitriptyline poisoning, and aspirin poisoning, and also paracetamol poisoning. Organophosphate poisoning very important. The presentation same. Hyperhidrosis, depression, pinpoint. Mydriasis where Dr. Hira? Where was mydriasis poisoning? Mydriasis, dilated people.
Atropine.
Yes,
No.
from atropine.
Atropine cause constricted people.
Opioids.
Opioids. Or tricyclic antidepressants. Okay, these are the cause for the dilated people or mydriasis. So even only one point other than this depression, hyperhidrosis, just only by seeing the people we can do diagnosis. Okay, so this way you have to remember the poisoning case. Though I'll give few PDF more, all enough this PDF, but I'll give more PDF regarding the critical care. Those PDF, the poisoning part will be covered. Parkland formula, very important exam question, my DHA candidates and every candidates. Because why? Frequently asking Parkland formula. They give the percentage of the burn 3%, or they give, you have to remember strongly anterior surface of the arm, frontal part of the chest, or only head. So see, these are the 9%. Anterior surface of the arm is 9%. If they say both part of the arm, so 9 plus 9 is 18%. Either they give the percentage of the burn, neither you have to calculate what they are telling. Either anterior surface of the leg or both part of the leg, or frontal part of the chest, or back part of the chest. So we have to calculate. So what we have to do, Parkland formula, that percentile fluid requirement. My dear candidates, every candidate strongly memorize the fluid requirement. First of all, we have to calculate. Okay. What? First of all, the person they said only anterior surface of the arm, 4.5%. Or each side means only first side is 4 point and another side is 4%, means 9%. If the leg each side 9%, so anterior surface is 9, posterior surface is 9, it's 18. So this said only 9%. So see, just example. Weight 60 kg. So 9 into 60 is 540. Okay. Into 4 ml. We have to start the heart smell. They will not give any calculator. So you have to even my experience, just ask for a pen, or there's ask for a pencil. Just you can draw. So calculate it. So first 8 hour, give half, means if your calculation is 1600, 1600. So first 8 hour they ask how you'll manage. Initially, first 8 hour is the I have to give 800 ml. Then second 800 over 16 hour. So this calculation in Allah not medicine, but in lastly they give 2 to 3 example. Just remember those way. Though I'll give few example in mock, inshallah, so it will be more easy. So this way we have to do calculate the Parkland formula. CPR I discussed already in my cardiology, just shortly. Unresponsive assist. One candidate actually I don't have anything that they ask him, ma'am, sudden collapse. So we have to start CPR. Is that sudden collapse means what, my dear? If you ask this question to me, is it acceptable? Sudden collapse, assistal, these are the huge difference. Assistal means there's a no pulse, no consciousness, there's nothing. Sudden collapse means sudden collapse. It's not same. Assistal means assist unresponsive. You have to shout for the help. Open the ERA for the intubation. No breathing normally. We have to secure the breathing by intubation. There's no sign of the life, so we have to start CPR. Nowadays, this is the new guideline: 30 compression and 2 ventilation. This is the new guideline. So we have to remember this way and start the CPR, and we have to intubate the patient, and 2 drug, remember, adrenaline, and another is if needed amiodarone and atropine, whatever need. Just remember adrenaline, amiodarone. If patient ongoing VA, VT, you can try to revert, or we give the shock 300 joule, but we tried by any medication if any possibility to revert the rhythm. Shock 300 joule. This way we do resuscitation. Dr. Moshumi. Dr. Moshumi is here.
Yes, ma'am.
This question.
Collapsed on the sidewalk walking home from the bus stop. Immediately, the bus driver gets out of the bus and once it starts doing compression. The mother sees the child and also comes out to help. According to the American Heart Association, which of the following is the correct course of action in the presence of slow 15 compression and 2 ventilation, 30 compression and 2 ventilation, 30 compression and 2 ventilation at the rate of 120 per minute, 100 compression and 1 ventilation. I think it's 30 compression and 2 ventilation.
Yeah, but actually, Dr. Moshumi, I didn't discuss one word. One word I didn't discuss due to this question discussion. That's why I didn't discuss. I said guideline was, I said 30:2. I didn't say children or adult. I didn't say because this question only. So your case, Dr. Moshumi, is patient child, a baby. So what will be the answer? For baby? Try, try. Even if you try, it will be nice. Will it be the 30 or 15 or 100? What will be the answer?
30.
No, it's a baby. It's a baby. It's a 15. That's why I didn't discuss. So CPR for the children. Okay, CPR for the children. It's a 15 chest compression, 2 wrist beat. For the adult, 30 compression, 2 wrist beat. I just say nice guidelines. Our American height guideline we use an adult medicine is 30:2, but for the baby, it's a 2 fingers. By 2 fingers, if you pediatric, there's a many kind of practice of the pediatrics. 2 finger, they ask 2 finger. We have to compress 2 inch, and we have to give the compression by only 2 finger. It's not like adult, the compression, chest compression. No, clear? Clear? Dr. Moshumi, clear? 15 compression to ventilation. Thank you, Dr. Moshumi. Just for discussion, I just avoid 2 words. Dr. Badhon, is that my voice clear? So Dr. Badhon saying it's lowering the voice. Is that so or clear?
It's lowered, ma'am.
Lowered from my side, or everyone is okay or not? Anyone can unmute the mic and tell me, ma'am, is it okay or is it lower?
It's okay.
What about?
Ma'am, voice is okay, ma'am.
Okay, the Maha said. So, Dr. Badhun, I feel if I don't know why you are facing, is that my side lower voice or Dr. Moshimi says lower voice? I don't know. I feel my side voice is okay. So, 15 compression to ventilation is a patient is a baby. That's why. And 30 students adult is flail chest. Very important exam. Exam question, commonly asking question, flail chest, diaphragmatic. After these are the hot topics for the exam. Actually, I do summarize what we have to know. That's it. Because everything not possible to touch. What we have to remember for the flail chest, after trauma of the chest, 3 ribs become fractured, broken down, close together, or pieces of bones detaching, which cause paradoxical respiration. This failed chest means either patient fall down or car accident or brain trauma. So paradoxical respiration, shortness of breath, chest pain which goes towards the flail chest. Management oxygen. So analgesia, we have to give initially paracetamol or intercostal block. If worsening, fatigue and fear and respiratory rate is worsening, we have to give intubation. Exam will remember only 2 words: brain trauma, car accident, paroxysmal respiration. Just nothing to remember. X-ray should refracture. That's it. So flail chest, I have to do intubation if there is oxygen dropping. No need to remember oxygen analysis. Just remember intubation. Second, diaphragmatic rupture exam question. Diaphragmatic rupture question, they ask how? Blunt trauma, burst injury, okay, but pressure within the abdomen raises so quickly with a sudden blow to the abdomen causing a burst in the diaphragm. It is a common sight for the left side. Respiratory distress, diminished breath sound, also see the picture, diaphragm injury. So these are the picture. And remember, regarding the diaphragm injury, they asked regarding the extra finding, raised left hemidiaphragm, air failure, everything they give exam. And we have to do CT thoracoabdominal for the diagnosis. So either they give this X-ray or they will give the investigation purpose, and you have to do the diagnosis for the diaphragm. So strongly you have to remember this raised hemidiaphragm is the diaphragmatic rupture. Esophageal tear, very important. Esophageal tear, my dear candidates, remember very carefully that Borhep syndrome, already discussed, spontaneous perforation of the esophagus that result from a sudden increase intraesophageal pressure. There will be the biggest pain. There's a subcutaneous emphysema. That's it. Widen pneumoperistoneum. This many candidates personally know him. Ma'am, why not is this? Why it's esophageal tear? Many candidates. So widen pneumomediastinum is the only one clue for esophageal tear. Pleural effusion is goes towards the esophageal rupture. Okay, this question will be discussed with me, Dr. Ifada. First question.
Yes, ma'am. A patient presents to the emergency department 30 minutes after being involved in a traffic accident. Physical exam reveals elevated GVP. Auscultation of the chest reveals normal L entry bilateral with muffled heart sound. Which of the following is the most likely diagnosis? A. Pneumothorax. B. Hemothorax. C. Cardiac tamponade. D. Acute coronary syndrome. In this patient, traffic accident with elevated GVP and the air entry bilaterally normal with the muffled heart sound. So I think this patient C, cardiac tamponade.
Excellent, excellent, Dr. Ifada. Cause what is the strong point?
Muffled heart sound with elevated GVP.
Yeah, excellent. Thank you, dear. This is the strong point I already discussed. The second question will be discussed with me, Dr. Sherin John.
Yes, ma'am.
Yeah.
I'm a 24-year-old patient presents the emergency department unconscious. The physician sees in his chart that the patient has a history of drug addiction. Physical exam reveals absent gag reflex. Which of the following is the most appropriate course of action?
This question was discussed. Very important question was this in the mock. So remember the point and they'll tell me the answer.
The patient is unconscious.
Second. Okay, tell me your answer. Right.
Intubation.
Yeah, yes, the answer is intubation. First of all, where is my point that I am asking frequently that gag reflex absent. This is the point. A strong point to doing intubation. Clear?
Yes,
okay, thank you. So thank you to both candidates, done very nice. So hemothorax question, very important exam question. Shortly I want to discuss regarding the hemothorax. Blood accumulation in the pleural cavity, they give this scenario, they give this excess. So you have to remember this hemothorax, blood accumulation in the pleural cavity, there's a downless hypovolemia due to massive hemothorax. Chest X-ray initially to see in case shadow on a supine X-ray. We have to give or we have to do oxygen first, and for cross-matching for the blood transfusion, but chest tube. Hemothorax is not tension pneumothorax. Hemothorax is we have to do evacuation blood by development. We have to prevent development of the empyema by chest tube is needed and is often less slow. So we have to insert the chest tube. So hemothorax, pneumothorax, they give this scenario nicely. Very important. First of all, remember hemothorax. We have to give only chest tube. Patient presented to my hospital dullness to percussion. JVP not raised. Hemothorax, JVP is not raised. X-ray homogeneous opacity. For the pneumothorax, hyperresonance. Pneumo, hyper. It's a dull, it's a hyper. Raised JVP. Don't be confused with muffled heart sound. Exam question. If raised JVP with muffled heart sound, answer cardiac tamponade, because muffled heart sound never possible in the pneumothorax. Hyperresonance lung feed all goes towards the pneumothorax. Chest is a hyperclastosency. Okay. The toxic shock syndrome. Staphylococcus aureus typically manifests toxic shock syndrome, low blood pressure, malaise, confusion. But remember, for the toxic shock syndrome, it develops characteristic rash, which causes rash disformation, high WBC, low platelets. So fever, hypertension, diffuse macular erythroderma, disformation. These are the picture. We have to see there's a more organ damage, gastrointestinal. There will be the kidney injury. So these are the toxic shock syndrome. Exam question: hereditary angioedema. Exam C1 stress inhibitor. Orbital blowout fracture, not so important. Just if they give this picture, maxillary fracture or ethmoid bone fracture, they cause a periorbital ecchymosis along with the upward gaze. But exam hereditary angioedema, paid question. They ask commonly exam. So hereditary angioedema, remember, is a genetic history and there's a positive family history, and there will be the low level of exam question, low level of C1 stress inhibitor. So we have to instruct, we have to administer C1 stress inhibitor concentration. Urethral injury, remember, my dear candidates, pelvic fracture. I don't know why my candidates do wrong. After pelvic fracture, if blood, the external urethra, it's a urethral injury. Many candidates say, why not pelvic fracture? Why it's a urethral injury? Only one clue blood at the urethral, external urethra. It's a urethral injury. Perineal bruising, along with, if you do rectal examination, inability to palpate the prostate, there is a high reading prostate. Okay. We have to do retrograde exam question, how we have to do, and we have to assess urethral injury by retrograde, just paid question, exam surgery question. We have to do retrograde urethrogram to see the urethral injury. Suprapubic catheters, initially all are the exam question. These topics all are the exam question. Either what is the diagnosis, second how you will investigate, third how you will manage. All are the exam question. Compartment syndrome is still not so common, just remember shortly. After any traumatic injury, patient develops sudden high blood pressure with compartment. If patient severe pain, blood supply will be all occluded, and the pain, pallor, paresthesia on the site of the trauma, myoglobinuria, we have to manage according to IV fluid management. Aortic disruption already discussed many times, just shortly. Commonest cause after RTA, and we have to remember this widening of the X-ray as esophageal tear. Aortic dissection and esophageal tear, widening mediastinum. Strongly remember. Don't be confused. Pulmonary condition, not so important. Hypothermia, just remember. Though it's discussed on in the cardiology, J wave hypothermia picture. Below 35, so see the J wave, Osborne wave. Core body temperature below 35. Okay. Severe hypothermia, many case complication by the presence of alcohol intoxication. Just remember J wave finding, mild hypothermia, external rewarming, or severe hypothermia, we have to give active or core rewarming presentation. Okay. So this last question will be discussed with me, Dr. Not last, another one was there. This question will be discussed with me, Dr. Tamanna Taharim. If Dr. Tamanna Taharim is not here, this question, Sneha is here or not? Sneha?
Yes, ma'am, I'm here.
Yeah.
A patient presents with sudden onset of chest pain and tightness, shortness of breath and rapid breathing. Physical examination reveals a tracheal deviation, decreased breath sounds, decreased fremitus and hyperresonant percussion. Which of the following is the next best step in management?
So Dr. Sneha, tell me your point. That ma'am, these are the point I am thinking. So this way you have to tell me.
Yes, ma'am. So this patient has got a sudden onset chest pain and tightness, shortness of breath and rapid breathing. So that means his breathing is compromised, and physical examination reveals structural deviation, decreased breath sounds, decreased remitters and hyperresonant percussion. Uh, and this sounds like a pneumothorax, ma'am. So initial management.
Sudden. First of all, your clue, Dr. Sneha, is a sudden. So it's a what type of pneumothorax? It's a
Tension pneumothorax.
tension pneumothorax. Excellent. So what you have to
I
do?
think that will
Excellent.
be needle decompression for the
Decompression. Excellent. Yeah, it's a needle decompression. Excellent done. Thank you, dear. This way
Thank
you
you,
have to
ma'am.
see sudden onset. It's a tension, and you have to do needle decompression. Actually, I have to analyze the scenario. And it's easy to answer, though we have to understand the scenario. It's easy. It's a hypertension. Excellent letter Sneha. This ma'am is a hypertension. It's a pneumothorax. But but she was confused. Either it's a normal pneumothorax or tension pneumothorax. So normally, normal pneumothorax, we have to see the 2 centimeter above below the extra size symptoms. But this is sudden. It's enough clue for doing the needle decompression. There's some notes. There's some notes short. Every points are very important, very important. Just remember those notes shortly regarding thiazide toxicity, digoxin toxicity. These notes will be given. Just I highlight all are the points which are the exam question. Just remember all the points. So second question will be discussed with me. Can you mute the mic? Who unmute them is really very tough. Okay, there, Dr. Tamana, you are in the duty. Understand? So this question will be discussed with me. It's the doctor. It's a Dr. Pallavi. Dr. Pallavi, if not here, Dr. Badhan.
Yes, ma'am. I'm here. Which question?
Oh, you didn't get the question. This one?
No, ma'am. No, ma'am. I'm seeing the notes only.
You are seeing
Yes.
only note.
No.
Who was able to see the my question? My question is here.
Ma'am, I'm saying. Yeah, an alcoholic patient. Is this the question, ma'am?
Yeah,
Now
yeah,
I
yeah.
get it. An alcoholic patient presents to the emergency department with non-stop vomiting after trying to consume alcohol after taking disulfiram. Which of the following is the most likely arterial blood gas status of this patient? Okay. Non-stop vomiting. So severe vomiting is going to metabolic alkalosis. Ma'am, I will go for metabolic alkalosis.
So severe
My
vomiting
clue
goes
here
towards
is severe
alkalosis.
vomiting.
Okay, excellent. Yeah. Dr. Badhan, you done excellent. So your strong point, ma'am, is a vomiting, so it's a metabolic alkalosis. Nice done. Thank you, Dr. Badhan.
Yes.
So this way, this is the
Thank you.
question very important. Question was done, and this notes every point very important. Actually, is every point I highlight those points which is exam points. Just remember those points, and shortly repeating hypophosphatemia, most common affect organ damage in the spleen. Okay, just remember there's Jesus scoring in eye opening, verbal response, motor response, and you have to do the Jesus scoring. My heart candies, DHA candies, and emotions. Remember this Jesus scoring. Okay, and massive blood transfusion reaction later. This question will be discussed with me, Dr. Pallavi is not here, so Madhya Bhatt. Dr. Madhya
Yes,
Bhatt.
yes, ma'am.
Yes, ma'am.
So Dr.
A
Pallavi
patient.
is here, right? Okay,
Yes,
okay.
ma'am.
Pallavi,
Yes.
Dr. Madhya, I'll ask second question if it are. Okay, okay,
Ma'am,
okay, Doctor. Yeah.
Yes, ma'am. A patient is playing soccer. A patient is playing
outside.
soccer outside when he is studied by a bee. After a few minutes, the patient is in respiratory distress and collapse. Which of the following best immediate treatment for the patient? Acha. Antihistamine, norepinephrine, dopamine. Antihistamine, soccer and bee after a few minutes. Patient is respiratory distress and collapse. Acha. Ma'am, antihistamine, norepinephrine. Antihistamine, ma'am.
Dr. Madhya Bhatt.
Ma'am, it's epinephrine.
Epinephrine.
Excellent. So this is the answer is epinephrine. Why? Because there is a patient collapse, right? So epinephrine we have to give this explains the classic symptoms of this common allergen followed by respiratory distress. Respiratory distress not simple allergen. It's a life threatening. So you have to give epinephrine first. Okay.
Yes, ma'am.
So thank you. Just shortly, I want to discuss the complication of massive blood transfusion, hypocalcemia, hyperkalemia. They asked regarding the hyperkalemia management and regarding the hyperkalemia metabolic alkalosis. Just remember those points and the high use point. I'll give all the points later. The PDF will be uploaded. So thank you, my dear candidates. Today I'm ending my session. Hope all enjoy my session. Thank you. If anyone have any question, can discuss with me in my session or my group. I should try to strictly maintain my group rules, my PDF, my lecture. All candidates try their hard best to join my session. It's from myself, my feelings, my dedication only for passing every candidate in first attempt. So be careful. Be careful about that. So no need to recommend. No need to break the rules. Okay. Thank you, my dear candidates. Assalamu alaikum to you all. I am ending my session.
Thank you, ma'am. Assalamu alaikum.
Assalamu alaikum.
Thank you, ma'am.
Yeah.
Thank you.